going over chapter 20 in the Davis book. This is caring for the child with a neurological or sensory condition. Of course, you remember the central nervous system, which consists of your brain and spinal cord, and then your peripheral nervous system is everything else. So your cranial nerves, your spinal nerves, your sensory organs. Okay. Let's look on page 681. Under the growth and development, I want you to read this and make sure you understand the effect of neurological conditions on a child. Cerebral palsy is a big one. Just make sure you read through that. Altered level of consciousness on page 682. Some winks and lollipops in here. So altered level of consciousness is a big one. It's the most common cause of children of altered LOC in children. Infections in the brain, meninges, very important. So you may see that if a child has a contusion or coma even, you see the stupor. Unconsciousness is a state, important to know, wink and lollipop, of where the cerebral function is depressed. This is increased sleeping. I have this written in my book, increased sleeping, okay? The altered LOC, and then the unconsciousness, of course, could be up to a coma, a state of unconsciousness when the child cannot be aroused even by painful stimuli, okay? There's a chart in your book on page 682. It's also listed over here of the different types of terms and states. So alertness is what we all are, hope to be right now. I hope you are. Lethargy is speaking in a loud voice. They appear drowsy, but you have to kind of speak loud to get them aroused. Obtundation is shaken gently to arouse. Stupor, they have to use painful stimuli. And then coma, they apply repeated painful stimuli. And if they don't respond, that means that they are in that unaroused state. Okay, so just be familiar with those terms. On page 684, you have this chart, table 22. It's here as well. Late signs and symptoms. So early signs was here, late signs are here. Be familiar with the ICP in infants, those terms. Collaborative care. So this is our Glasgow Coma Scale. It's here as well. So how do you rate somebody's, or how do you determine what state of unconsciousness they're in? We use this pediatric Glasgow Coma Scale. Okay. So, and you need to know this, what does it consist of, okay? And it talks about it right here, so another wink and lollipop, okay? So 3 things. It consists of eye opening, motor, and auditory or visual responses. So the eyes, the motor, and then the auditory and visual. So you need to know those things, wink and lollipop, okay? The most essential part of the nursing assessment after a head injury is checking the level of consciousness. So you might want to write that down. I'll say it again. It's on a sticky note in my book. The most essential part of the nursing assessment after a head injury is checking the LOC, the level of consciousness. Okay? So the nurse carefully monitors, measures, and documents the vital signs, LOCs, reflexes, pupillary reaction. So make sure you understand that according to the facility policy. And that's on page 684. 686, it's just got a medication box talking about mannitol. Read through that. It's right here. And then underneath that it starts talking about barbiturates. So another wink and lollipop. So they may also be administered to reduce the ICP, okay? You are charting the blood pressure, monitoring the blood pressure, volume status, and of course the use of steroids with increased ICP is controversial. So the corticosteroids have no effect on the brain edema, cytotoxic brain edema, and it results from the infectious or hypoxic disorders, but the use of the other steroids is not advised because it actually increases that ICP. So you're carefully monitoring the volume status and blood pressure. Increased blood pressure is bad. That's written in my book. Increased blood pressure is bad when you're given these barbiturates. You do not want to see an increased blood pressure. Okay? All right, page 687 is talking about seizures and epilepsy. A seizure is an electrical disturbance within the brain, and it directly results the motor function of the body. Okay, sensation, cognitive ability. Make sure you understand what that definition means. And then we have some just charts over here. It talks about different types of seizures. Febrile seizure, and I can tell you a story about in the ER when I worked down there, checking a baby in, triaging a baby, having a seizure in my arms. Temp was 105 and then started seizing. And then epilepsy is another seizure disorder. And you have different types, and we'll talk about those. Okay. On page 689, it's a focus on safety mechanism. This is just the EEG on a child. But the focus on safety, important. Make sure you read through this and understand some winks and lollipops here. So the biggest thing to do, right, is to maintain the patent airway. We have to maintain an airway. So when you turn them on their side, you're not going to turn a newborn on their side if they are brand new, having a seizure, if they've been NPO, hopefully, you could, it's not going to hurt, but your telltale sign to turn them on their side is you don't want them to aspirate, right? You don't want them to aspirate, so you're putting them on their side in the sideline position. Huge thing. Remove the objects from the bed. I want you to add this one to this. Write it in your book as a wink and lollipop. Remove objects from bed. You don't need them hitting a dinner tray that's right in front of them. You don't need them cutting their head on the remote that's in the bed or anything. So remove the objects from the bed. Okay. Page 691. We're going to start talking about neurological conditions, inflammatory neurological conditions. These are just other types of seizures, the tonic-clonic, absent, myoclonic, and atonic, okay, before we move on to the neurological. So tonic-clonic, that's our grand mal seizure, okay, that's when they're flailing all over the place. Absence is when they're kind of daydreaming, staring into space. You may see that more common in children. Actually than the other one. And then myoclonic is a brief jerking, and then atonic or akinetic, and they have like drop attacks. They just kind of slump over. So just be familiar with those terms. All right, now page 691, the inflammatory neurological conditions. Meningitis. It's inflamed structure of the central nervous system caused by infection. Okay. So taking you back to A&P, it affects the dura mater, the arachnoid mater, and the pia mater part of the brain. It's a bacteria, usually Streptococcus pneumoniae, Neisseria meningitis, Escherichia coli, Haemophilus influenza type B. So there's just those terms. You don't have to memorize them, but just be familiar with them. Then it goes on down talking about the etiology of the meningitis. They present sometimes with vague symptoms. maybe not acutely ill yet, but we are usually doing a lumbar puncture for CSF fluid to see what that comes back as. Okay. Signs and symptoms. There's lots of notes in my book, so pay attention. This is some winks and lollipops. Okay. Very, very important. Know the signs and symptoms of meningitis. All right. So these are for older children. Fever and headache. Older children, about 5 years old. Okay. You're taking them to an isolation room. They have a fever, which means they're what? Infectious. All right. Stiff neck. So location of the pain, neck range of motion. You're seeing all of this here. And then lethargy, irritability, like mood. I would write mood out beside here. Okay. You will not see this in encephalitis, which we're going to talk about, only in meningitis. Okay. Nausea, vomiting. So this is a reaction to a pupil assessment. Okay. When you get back the meningitis results, it's based on what that lumbar puncture says. Okay. CSF results on bacterial meningitis. It's not an encephalitis, but if you see bacterial meningitis, that does not go with encephalitis. Okay. Brzezinski sign. This is conducted when the child's laying flat. Wink and lollipop. You need to know Brzezinski sign. Okay. They attempt to raise the head towards the child's chest and place the chin on the chest. If there's pain or resistance, immediately when that hip's flexed, that's a positive sign. Okay. You can read about Koenig's too, but I want you to know that Brzezinski. This means that there's meningeal inflammation and it's painful. That's on 691 and 692. Collaborative care. All right, let's talk about this. So, in small infants, ICP, intracranial pressure, can be subjectively monitored through the anterior fontanelle. Remember, if we have a bulging anterior fontanelle, that means that there's increased ICP. Okay? It can be combined with emesis, high-pitched cry. They don't want to eat. They're very irritable. But that's important. Wink and lollipop. Okay. And then another open fontan with open fontanelles and enlarging head circumference. You may see that as well with ICP. So just know all of this. Winks and lollipops. Okay. There's the different types of seizures that we talked about. It's on table 23, and that's on page 688. All right, this is the Brzezinski sign for the meningitis. Koenig and Brzezinski's. Okay, 5% of adults present with this. And this is a child that's tested on too. Just that neck rigidity. Okay. All right, let's look. Go back to, or go to 692. We'll continue that. Medical care. Okay. So this is a CT scan being done on a child to look for that increased ICP. Another wink and lollipop is bacterial meningitis is treated promptly with IV antibiotics. It can go south in a hurry, so we get those IV antibiotics on board. Okay. Going back up here, one thing that you're going to do, and you can write this in your book because it's in my book, but you're going to measure the head circumference every shift. Okay. You're going to see it enlarge with the increased ICP, so you need to be measuring that head circumference every single shift. All right. Some signs and symptoms. Again, we're going to talk about the different ages. Headache. This is for an older child. I say about 5 years old or so. Okay. Photophobia is for an older child. Lethargy, you're going to see in a newborn. Remember, you're going to see that high-pitched cry. You're going to see the irritability, anorexia. They're not wanting to eat. Okay. And then collaboration care is talking about the complications resulting from encephalitis or meningitis. So you need to be able to compare encephalitis with meningitis and know the differences. Okay. One more thing on page 693. It talks about the different drugs, and we're going to talk about baclofen to start with. Okay. It can be given through an intrathecal pump. Okay, this is an implantation of the pump to deliver the medicines in the intrathecal space to decrease spasticity. And so you see it's just placed right here next to the spine. They put the baclofen in this intrathecal pump, and it delivers directly into the cerebral spinal fluid, and it decreases that spasticity that can happen from seizures, can happen from meningitis, so it's important to know. Another one we're going to talk about is Dilantin, phenytoin, okay? This is used to treat the tonic-clonic and partial seizures. Know this information right here. Get it to highlight. Wink and lollipop. The therapeutic range is 10 to 20 micrograms per milliliter, okay? And then you would still occasionally monitor that on the CDC. You know, you have to get Dilantin levels anytime they're on that drug. Reye syndrome. This is a rare illness, and it's caused from acetylsalicylic acid. Before I talk about Reye's, let's go back. There's a section in your book, sorry guys, that talks about DEET, and it's on page 693, right here. Community education. So DEET, you do not ever use DEET for an infant, okay? I hardly ever buy it, and my children are grown, and I'm grown, but DEET is very bad. It can cause encephalitis, so be careful when you buy any type of insect repellent with DEET in it. All right, now let's talk about Reye syndrome. Or Reye's, I say Reye's, however you want to say it. It's a rare illness, happens usually between the ages of 4 and 14, but it's advised not to ever give a child less than age 18 an aspirin, okay, because of the Reye syndrome. It's associated with viral illnesses, you know, people giving kids the aspirin if they have a fever or whatever, but symptoms include hypoglycemia, short chain of fatty acids, restlessness, lots of seizures, vomiting, loss of consciousness. So you need to educate your parents when they're coming into a peds clinic. Make sure that they understand not to ever give aspirin, okay? There's different stages here. Make sure you read through these. It can start out just nausea, vomiting, decreased liver function, and then it goes into respiratory arrest. So it can go bad quickly. But make sure you associate the Reye syndrome with acetylsalic acid, okay? Wink and lollipop. You need to know that. Increased ammonia's in the blood, it says, but they just become really deathly sick. Guillain-Barré. So this is another one. Guillain-Barré is another rare neurological condition. They cannot breathe independently. It attacks the immune system, producing antibodies against the own nerves. Very, very scary, and causes paralysis. They cannot breathe on their own. Signs and symptoms is muscle weakness, numbness, pain, paresthesias, paralysis. So make sure you understand wink and lollipop, that this Guillain-Barré leaves them where they are unable to breathe independently. Okay. I highlighted too much, but they are unable to breathe independently. Okay. Monitor for respiratory efforts. Okay. If they're still having trouble breathing, make sure you're monitoring those respiratory efforts. Okay. Some collaborative care. Diligent vital signs. Okay, you're going to be monitoring them for respiratory compromise. And they may even have a parenteral or enteral feeding tube to maintain nutrition. Okay, and this is because they start experiencing dysphagia. So that's important to know. So this is what I want you to write down for Guillain-Barré, okay? So if there's decreased lung sounds, decreased respiratory rate, and decreased O2 sat, you need to be calling the rapid responsive team and prep for intubation immediately. I had a student actually tell me this, that it helped him to remember, but GB, Guillain-Barré, it starts on the ground and it goes to the brain. So ground, G, brain, B. So it starts lower and then it goes all the way up to the top. So you start seeing some numbness and tingling, and then it continues to climb up the body, affecting the respiratory efforts and then the brain. So that may be an easy way for you to remember that. There's some medicines that have aspirin in them. Dealing with Ray's syndrome over here, need to point out table 26. Let's see, and that's on page 696. So just make sure you read through those, because things that you wouldn't even think of do actually have aspirin in them. They make a children's Pepto-Bismol that does not have the aspirin, so don't ever give your kid, or advise a patient to give their kid adult medication. Make sure it's prescribed for their age group. Some neural tube defects on page 698. Spina bifida is a big one. It's a group of birth defects, and they have malformations in their brain and spinal cord, several different kinds. There's a picture here, and I'll pull it up in class, but the different types of spina bifida. There's a spina bifida occulta. There's a meningocele, and then there's a myelomeningocele, which is the most severe one, okay? And they're described in your book as well. Under prevention, so we know what's the biggest thing that would prevent spina bifida? Folic acid during pregnancy, right? So make sure, wink and lollipop, you remember that folic acid is going to prevent the spina bifida. Another big thing to do with spina bifida is under your focus on safety at the bottom of 699, latex allergy. We never, ever, ever use latex with a child with spina bifida. They're very sensitive to that. So wink and lollipop, don't ever use latex with a child with spina bifida. So this is a normal child, okay? Normal brainstem, normal spinal cord. And then we have our Chiari-2 malformation, spina bifida, and this is where the meninges are protruding out, sometimes out of the body, sometimes it's just right there at the edge, like the occulta, but the myelomeningocele is the most severe. See, this occulta is just like a hairy patch, and then the bulging, and then this can actually be on the outside and open. Hydrocephalus, and this is another picture before we go to that one, of the different occultas. The cranioschisis, encephaly, where they're born without the brain, encephalocele, where it's kind of herniated outside of the meninges at the bottom of the spinal or the brain stem, and then you have the anencephaly. This is the occulta. This is the closed spinal ditrosum, dysrhapsum, however you say that, meningocele, and then the myelomeningocele. That one's just kind of this vertebrae getting into those arches, into that sac. But you would have to do, of course, x-ray to see that right. This is another one, the occulta, and I have a story about a baby I took care of in NICU with this. I'll tell you about that. No latex, of course. This is after a repair. And now hydrocephalus. So this is derived from a Greek word hydror, which is water. And then kephal is head, or cephal, however you want to say it. I think it started out as kephal, but and so hydra is water, hydrocephalus. So this is they used to call these babies the waterhead babies. Very sad situation. They end up with a shunt to drain that. But you need to be observing for, of course, ICP, measuring their head circumference daily, Q shift usually. It's difficult for them to hold their head upright. These are very critical patients. Cerebral palsy. This starts on page 702. And this is after the shunt is placed. 702 talks about measuring the head circumference. All right, here we go. So it's the most common permanent disability in childhood. It cannot be detected before birth, okay? Sometimes it's caused during birth. Sometimes it's caused right before birth. They can have a stroke in utero, but about 10,000 babies are born each year, and they'll develop CP, okay? I want you to read through that and just understand the different types. There's a case study, and there's another child with CP. This does not mean that they are intellectually disabled. This means that they are physically disabled, okay? Physically with a need. So don't assume that you're dealing with an intellectual special needs child. This is just a physical part. Most of these children are normal, intelligent when it comes to their intellect. Okay. There's a case study here I want you to make sure you do. Okay, talking about CP. And then TBIs, okay, traumatic brain injury, a leading cause of death in children in the United States, in children, okay, 0 to 14 years old. And we talked about some of this with the bikes and the motor vehicle, and that kind of all ties in to motor vehicle accidents, ties into that, okay. Make sure you read through that. 706 starts talking about abusive head trauma. You need to see what the signs and symptoms are, This is non-accidental, okay? This was like shaken baby syndrome. Make sure that you're monitoring that LOC, okay? Number one thing to monitor with these children is their level of consciousness, okay? Still talking about CP. All right, I want you to go to page 711. Astigmatism and strabismus. It's talking about different eye disorders. Let's see. So just make sure you read that. Strabismus is cross-eyed appearance resulting from malalignment. There is a pseudostrabismus that I want you to be familiar with, okay? Wink and lollipop. This is where it's just lack of muscle control in the eyes, okay? Babies are not born with that muscle control. So in newborns, it's a lack of muscle control to regulate eye movement, and it's called pseudostrabismus, okay? I need to know that. And that is it for chapter 20.